Good morning, everyone. Thank you. We have talked about the diagnostics in our cataract surgery, and next very important thing is the lenses what we choose. So nowadays the requirement of the patients are entirely different. They demand new technologies, and we have a lot of them. So we have to decide the lens as per the visual requirement of the patient. So just to show how you have to see whether patient wants to do a near thing, distant, or including intermediates. We'll see case wise. So these are the lenses which are available. Ideally, a lens should be has a spheric surface. It has a polymer material, low refractive index, and not a material which is not associated with glistening. Then it should be UV blocking and hydrophilic acrylic material, which we all know, hydrophobic acrylic, which we all want to use. So these are the modern lenses which are available. We say in the pseudophakic we have a monofocal and the bifocal lenses or the multifocal lenses. There's a new thing which has come up is the monofocal plus lens. Multifocal can go with the diffractive refractive, and the other can be extended range of vision, and then it can be accommodative IOLs also, which are no more used most of the time here. So normally we'll see these how we use these bifocal, trifocals and all. So before a word of intermediate vision, very important because we need to see what a patient want. Because intermediate vision can be different for different people. Intermediate can be using a tablet or a computer, can be around 40 centimeters, and shaving or styling hair can be around 80 centimeter, and it can be cooking, checking price tag, and computer work for various other peoples which we look. So this again is very important part. So we do the counseling, and we ask the patient to choose a technology, whether it is a conventional or a femto, and the lenses again monofocal, multifocal, or extended or trifocal lenses, or the CRV lenses. Now monofocals are most widely used. We all know about that. So we can use in all the patients. Definitely choosing the right lens, which the properties I talked about. So this goes in most of the lenses. Now let's go to the other multifocal lenses. So this is a case where this 67-year-old lady with bilateral cataract, and patient wants spectacle independence. Now this why it is being written is, this is very important. Patient has to demand something. You have to tell in counseling, that is very important, but patient also demands something, that he wants spectacle independence. Housewife, loves to read magazines, doesn't drive. Again, very important because you need to know whether halos or glare will be there, and wants to do near work and watch TV. This is the ideal case for a multifocal lens. Now multifocal lenses, they desire spectacle independence, have in patients which have been myopic and enjoyed being glasses free for reading, will accept a slight drop in optical quality, does not do much of computer laptop work, engaged in nighttime reading, and cool, composed, cooperative personality. This again is very important. If a patient is fussy, you don't go in for a multifocal lenses. So this is why we chose a multifocal lens here. Now here the diffractive multifocal has been chosen. You see there are two different near and distant vision, two spots out here, the focal spots out here, and but these have some disadvantages where they create a halos and a glare and reduce contrast sensitivity, and most important what we have talked about, problem with intermediate vision. So it reduces the tolerance to astigmatism also, because rightly said, we have to use toric lens whenever there is a bit of astigmatism. So this is a second case where a young patient, congenital cataract, is a garment businessman. He drives at night and loves to have off road drives. Extracurricular activities, young patient, table tennis and running. We considered for an EDOF lens here. Now EDOF is extended depth of focus lens. This implantation was done, and patient is 6, 6 and 6 for initial 3 months, but reduced to N8 after 3 months. Now this is the intermediate vision in this patient is excellent, because this is what the EDOFs do. This is another example of a simple EDOF where a symphony was implanted. Here again, the patient wants to drive at night, and extracurricular activity is like golf and tennis and all. Now, why EDOF or ERVs? Again, patient has to desire a spectacle independence. Mainly, we use it for working professional with active social life. Near vision is mainly mobile phone users with occasional reading. They are not good for a near vision. They are more better for an intermediate vision. ideal for corporate executives, doctors, surgeons, housewives, professional photographers, and they are desires good optic quality with minimum glare and halos. The glare and halos are less as compared to the multifocal diffractive lenses which we talked about. This is a diffractive lens which is available. One is the Symphony, other is the Vivity from the Johnson and Johnson. So they both have a different technology here. Uh, this is the, I am not going to the videos. This is something the congenital cataract which was implanted with Vivity, and patient is happy. But again, with an add of around 1.25 for near has been added after 3 months in that young patient. Now, this is another case where a 52-year-old male patient, IT professional, and bilateral cataracts, works on all digital devices and drives at night. Bilateral synergy implantation was done. Now, what is synergy? Synergy is a, sorry, no, this was bilateral panoptics was implanted in this. This is a trifocal lens where you have three different focuses and three discrete focal points for distance, intermediate, and near. And they give a higher spectacle independence and mainly used for all these people who want to be very active and want to have a near vision also, because if you are reading more like most of us offices and all that doing work, you need these type of lenses here. So patients who do frequent work on computer, laptop, like office-based professionals, account data inputs, now they need constantly shift focus from computer screen to reading material. Now all these are the patients which are to be counseled for the trifocal lenses, and like they are not involved in precision work like machinery, because very near work if we are doing even with the best of the trifocal or multifocal lenses, it will be very difficult to do that because near vision can't be the perfect here. And for all the patients, it is important that to choose who are not high strung, anxious, and they have a realistic expectation, like, and open to counseling. Counseling, rightly mentioned before, it also is very important. Spending a lot of chair time before the surgery is definitely important, and if you spend a lot of chair time after the surgery, that will make the patient anxious. So this is video I'll skip, and this is another case. So here was the case when synergy was implanted. Now again, household activities are needed. Time watching TV teaches children social activity, cooking, driving, playing board games. Now, 61-year-old female active in life. Definitely, this was the vision pre-operative, post-operatively. Patient is having N6 vision and good intermediate vision. These are the continuous range of vision IOLs, combination of what you can say a trifocal and extended range of vision IOLs they have made and combined, and they leverage benefits from both ERV and multifocal or trifocal technologies. So they give us a continuous range of vision without drop off fluctuation plus higher spectacle independence. So this synergy is one of the lens which is being used by me. Just wanted to show that lens is just a simple, just like a Technis lens, and it can be implanted very well without any hesitation. So there is no learning curve involved here. This is just as simple as, only thing is you should know how to center the lens at the end of the surgery, which is important. And once it is loaded in the injector, you can simply insert it inside the eye. So this is simple insertion, and we all must go back and start using multifocal lenses if we are not using. This is again a same case where Triumph lens was implanted. Now Triumph is a lens from BVI, so no financial interest here. This is again a continuous range of vision lens where it is a combined technology between a trifocal and extended range of vision lenses, and the patient is again very happy here. So now this is a case where I'm talking about here the new concept which I told about, the monofocal plus. This is a 72-year-old male patient diagnosed with bilateral cataract, has glaucoma, right? And cup CD ratio is around 0.5 to 1, and wants spectacle independence, but because he has a glaucoma, we are not going here for a multifocal lenses. We plan for a monofocal plus lens. Now these lenses are very good. They give a lesser dependence of presbyteric glasses for reading, at least 45 50 centimeter. They can't be for 30 centimeter, and patients are extremely happy because they get a good intermediate vision, and the the look on the is just similar to a monofocal IOL. There are no rings inside, so there are no glares and halos. Comparatively, they are comparative to any monofocal lenses. So this is one of the lens which I hence you can see the beam split function here, how easily it extends to the far and the intermediate vision here. Now this is something which I wanted to show. This was implanted in a glaucoma patient because so easily it can be implanted. Here we don't want to use any lens which will further, we are not able to, patient is not, will not be happy with the multifocal lenses here because the vision will be compromised because of the damage in the disc. So again, simple insertion, no learning curve here. Go back, use these lenses, again very important lens. And this is changing most of the monofocal practice in my hospitals to these monofocal plus. Last is the a case of a patient with has a traumatic cataract. No, this is the same. We'll use another monofocal. We have used here monofocal plus. This is interesting where 77-year-old, my senior, a pediatrician, practices 3-4 hours a day, very active in participating in the IMA activities and meetings and all, and has been hyperopic, wearing glasses for 60 years. Now, pseudofoking one eye, the doctor never told him about a cylinder which he is carrying of 1.5 still having. Other eye has a cataract with a cylinder of 2.25, and he doesn't want a multifocal lens. Now, there, patient is very categorical, doesn't want, and we also don't want to give it because there is a mild ERM in both the eyes. So here, Technis eye hands, again, the similar monofocal plus lens was given and now can read at 60 centimeter, but near we need a 1.5 diopter glass is given. So, sorry, this is toric was implanted. Toric has been told and will be explained now in the future slide. So, for toric, my word, one liner will be it is a right of the patient to give a correct the astigmatism. All of us should go and do toric lenses, and it should be at least 15 to 20% of our practices. Don't think whether it is an Indian toric or a imported toric. Go and give toric, correct the toricity of the patient. So I'll skip this. Thank you very much. Sorry for the delay.